When your family's in need of medical care, where should you turn? Come to Englewood Hospital, home of the most advanced technologies and medical equipment. Home to Magnet Award-winning nurses who deliver compassionate professional care. And home to more top-rated doctors than any other hospital in North Jersey. For your family's health, come to Englewood Hospital. We're closer than you think.
Welcome to Dr. Gore's show. So today we're going to talk about epilepsy beyond the stigma. Epilepsy, commonly known as seizure disorder, is really a common disorder which has a lot of cultural, ethnic, and voodoo kind of thinking attached to it, and to kind of come to know what's right, what's wrong, what's just a cultural kind of stigma attached to it. We're going to talk about it in detail with an epilepsy specialist, which are very rare to find. So on the studio, we have Dr. Gautami Rao. Welcome to Dr. Gore's show.
Thank you for having me.
So Dr. Rao studied medical school in Bangalore. Then she came to New Jersey, did her neurology residency at UMDGN, and then she went on to study epilepsy at Yale, and she's been in practice since 9 years, and presently she is at Eastern Regional, New Jersey Eastern Regional Epilepsy...
Northeast Regional Epilepsy Group.
Northeastern Regional Epilepsy Center. And so let's define epilepsy. What's epilepsy?
So epilepsy is when you have more than one seizure, and there isn't a clear known cause for it. For example, a lot of patients come in and they have one seizure, and it can be because of sleep deprivation or because of alcohol or because their electrolytes are abnormal, and we all see that in residency. But we use the term epilepsy when it's multiple seizures, and these can be because of a genetic cause, or it can be because of a tumor in the brain or a lesion that we can't see on MRI, but we can only see on pathology.
Right. So it's usually what's defined as like people start having like convulsions, right? Like the whole body gets really tight. Either they have frothing in the mouth and they have involuntary urination and stuff like that. That's usually what we were taught in medical school.
Absolutely.
And those are usually those grand mal seizures, correct? Right. But you could have different kinds of seizures where the patient just becomes still and they just have no activity as such, and they just kind of black out. So walk us through what are the different kinds of seizures.
So there's actually over 200 types of epilepsy, which is one of the reasons why I love it so much, because I feel like I learn something new about epilepsy every day. And it depends on which part of the brain the focus is coming from. So you have complex partial seizures, which are the most common types, and those start with a confusional episode. It can also be a sense of fear, or it can be laughter in some cases. There's a condition called gelastic epilepsy, which comes from a certain part of the brain where patients laugh, and they become very confused afterwards. So if it's a simple partial seizure, you experience something but you don't lose consciousness.
Okay.
Complex partials, when people appear confused, they're blinking their eyes, or they're hearing voices, or they're hearing music, or even seeing images, and they're confused. And very often the complex partial seizures progress to the shaking types of seizures that we often see on TV, although now I think the media has been really doing a great job of looking at different types of epilepsy with all the different shows that are out there.
Right.
And within those complex partial seizures, there's 200 different types, because all different types of the brain present as different seizures.
Right. So we have different kinds of seizures which are, prevalent. How do you diagnose them? So usually the family member will notice there's some difference in the behavior, or they have these episodes after episodes. So they come to you, or they come to their primary care. What's the usual workup before you diagnose somebody with seizure disorders?
So the first thing, just like we're all taught in medical school, is history. And that is probably the most important part of epilepsy, because many seizures are not witnessed. So we really try to get a good story behind what happened, whether it's in the emergency room or in the hospital or in an outpatient setting. And that can be done through the use of talking to family, or looking at the chart, or very often talking to the patient themselves. EMS helps also. And then after that, we usually will order an EEG. And we do...
That's like a EKG of the brain. Where
Right, it's a brainwave test.
Correct.
And we use 16 leads, and there's actually a very specific way of doing it, which is which is an international standard. Everybody all over the world does the EEG the same way. And then people that are trained in epilepsy like myself, we read it. And you can have a 40-minute EEG, you can have a 24-hour EEG, a 3-day EEG, and the 3 or 5-day EEG can be done outpatient or can be done in the hospital.
Okay.
And then depending on that, depending on the history, we choose to do an MRI of the brain. Now it's standard of care that every patient with a first seizure does require an MRI of the brain with contrast. That's what the American Academy of Neurology guidelines state, and I think it's a good idea. And you can do that in-house or outpatient. And then based on that, we decide on which type of medications we choose, and there are about 12 medications. The other thing we do is taking all this information into account. We look at the brain waves, and different seizures present as different brain waves. So, and there's different meds for each brainwave presentation. So the great thing is now there's 12 to 15 medications for epilepsy, so we can really pick and choose.
Right. So the MRI of the brain is like a CAT scan, but it's much more sensitive without the radiation. And the whole idea for MRI is to look for if there's any tumor, if there's any growth, if there's any cause why somebody should have new onset seizures, because then the treatment might be different if there's a growth which needs to come out and stuff. So we've done the basic 2 investigations with either the EEG, MRI, and now the patient has come back to you. How do you start giving them counseling? Because this is a life-changing diagnosis.
Yes. Well, especially with adolescents, it's difficult, and with women as well, because, well, in the first group, adolescents feel like they're all powerful. And and epilepsy is a very scary disease because you literally lose time. 1 minute you're in your room, and the next minute you're in the hospital, and you have no idea how you got there. So it caused a lot of anxiety, and in the adolescent population, they really don't want to take medications. So we really tell them that this doesn't have to be a life-changing thing. Medications work, they help, and you can go on with your daily life. And our job is to make sure that we choose the right medicine to make sure that they don't have side effects. So I tell them, leave that part up to us, and your job is to make sure that you realize that this is something which you can get beyond and you can live a normal life.
Right.
And with women, the special concerns are multifactorial. I mean,
absolutely. We'll come to the woman in a second, but so adolescent, as you brought it out, you know, they have to be careful with swimming, they have to be careful with driving. So how do you counsel that part for adolescents?
Well, the most common type of epilepsy in adolescents is complex partial epilepsy. And the second most common is juvenile myoclonic. And both of these epilepsies are usually associated with normal intelligence, very highly functioning kids. So we tell them is once we get them on a good medication, they can drive and they can swim, but somebody has to be there with them.
Right.
They can't swim alone. So they can't just go off onto a beach and swim by themselves. They can bike ride. Hang gliding is probably not a good idea, and neither is jumping out of a plane or bungee jumping. But of course, this is what the patients want to do. So you have to tell them that this is a little bit risky. Now we have great medications that are not very sedating. So they're able to engage in athletics and do everything they normally do under our supervision.
So it's just a matter of counseling them that if they take the medication correctly and if their seizures are under control, they could go ahead and do day-to-day activity without limiting, but especially with high-risk behaviors like hand gliding and bungee jumping, we all have to be careful where we go from that. So, so let's go to medication. In general, there are, different kinds of medications in a different class of medication. We started with a really medication which had sedating effect and a lot of side effects to now which has limited, the use of it. But with the newer medication, we have taken off those side effects. So can you tell us in broad classifications of anti-epilepsy medications?
Sure. So there's an association called the International League Against Epilepsy, and it's the league that actually classifies epilepsy syndromes and helps with medications. So there's several different classifications. We should probably just look at the older ones and the newer ones. So the older drugs that we're all familiar with are Dilantin, phenobarb, Tegretol, quinine was used, primidone. You don't usually see quinine primidone used anymore, but you will, or but you do see phenobarb and dilantin used very commonly. Those are the older drugs, they're sodium channel drugs, and they cause a lot of side effects. They cause osteoporosis, and they interact with all of our medical drugs like Coumadin and digoxin. Then you have the newer medications like you have Lamictal, Topamax, and most recently Vimpat and Keppra. And now there's another drug called escalarbazepine, and several new drugs that are coming down into the pipeline. There was Patiga as well, but Patiga had some side effects, so it's still being worked out. So the newer medications, they have almost little to no effect on other medications that you can use.
Okay.
Or on each other. So Keppra and Vimpat are the two drugs that have no interaction with any other medications.
Wow.
So people that are trained in epilepsy, as far as possible, if it's appropriate with the type of syndrome they have, we try to put these people on those medications because they're not sedating, they're easy to use. Vimpat, you don't have to check levels, but Keppra you do, just to see what a good range is. And Keppra especially can be used safely in pregnancy, even though it's not FDA approved for that. We do use it, and I've used it, and many other physicians have, and it really, the pregnancy goes well, and the kids are of normal intelligence, and it works out really well.
Right. So enlighten us, because most of the anti-epilepsy medication we used to always tell, because it went through the liver bypass, to be careful with, especially birth control pills and, other medication somebody's taking. Is the newer medication still goes through the liver bypass or no?
No, it doesn't. Keppra actually acts on a receptor called SVC2 in the brain, and Vimpat has a mildly sodium channel effect, but it inactivates the slow sodium channels, so it has a different type of effect. The thing is, though, is that this JME that I was talking about is a primary epilepsy syndrome. It's called primary generalized epilepsy. In those types of epilepsies, sometimes Keppra and Vimpat are not the best choice.
Okay.
Actually, some of the older medications like Depakote, Lamictal, Topamax, those are the first-line treatment.
Okay.
So these drugs are good, but that's why it's really important to seek the consultation of an epileptologist, because every epilepsy falls into a syndrome, and not every medication is equally created.
Effective, right.
But the newer ones are good because they don't really go through that pathway. And Vimpat does have some caution with liver failure patients, but Keppra does not.
Wow. So I think the world of epilepsy has evolved so much. We're going to take a short break and we'll be right back.
When your family's in need of medical care, where should you turn? Come to Englewood Hospital, home of the most advanced technologies and medical equipment. Home to Magnet Award-winning nurses who deliver compassionate professional care. And home to more top-rated doctors than any other hospital in North Jersey. For your family's health, come to Englewood Hospital. We're closer than you think.
Welcome back. So today we have a specialist about seizures and epilepsy. So far we've talked about what causes epilepsy. Sometimes it's genetic, sometimes it's sleep deprivation, sometimes it's medication or infection or tumors. Once we have the diagnosis made, there are testing to be done to specify what kind of seizure disorder it is, and most medications are depending upon what disorder they fall into. Being a GYN, I'm going to always ask about women and epilepsy. Especially, I think I've seen young girls with seizure disorders, and especially Indian culture, a lot of times there's so much stigma attached to it. What's going to happen with my girl? Is she going to be fine? Is she normal? What's wrong with her brain? Has somebody possessed her? Is she going to be able to get pregnant or married? I think there's a lot of stigma attached. Even in today's day and age, we find. So how do you counsel a young woman, adolescent, or a young woman about, why it's important to be diagnosed correctly, and what medication would you give? Because there's always this pregnancy at the back of our mind.
So the first thing I talk about with women who want to plan a family and have been told previously that it's not possible because of epilepsy, or themselves feel that they won't be able to have a normal child because of the medications is that that's not true, because we do have newer treatments available, and that if you're in the hands of a specialist, there's ways to monitor this. So basically the approach to women with epilepsy starts in the pubertal age, but obviously not all of us have the fortune of treating them from that young age. We need to make sure that they are diagnosed correctly, they're on the right medications, they're taking them, because when epilepsy is not well controlled, it actually reduces your fertility. So because of the different hormonal changes, it actually reduces the GnRH agonists and affects your ovulation. And a lot of women, unfortunately, are put on Depakote, which reduces your fertility furthermore, and you know that that causes polycystic ovary disease. So it would be wonderful to catch these people at an earlier age, but if you don't, you catch them when they're married and they want to have a child, and everyone's told them they can't have one because they're epilepsy, or worse, it's hidden. I've seen many patients where the epilepsy is a big secret, and all of a sudden they come into my office and they say, I had a huge seizure. When I start digging, I realize this has been going on for many years and no one talked about it. So I usually talk to the entire family because I think it's important for, in most cultures, to have the entire family on board, the parents, the grandparents, and the husband. Obviously, that's really important, because once you start explaining to them and you talk about other patients and you talk about the different types of seizures, people really are on board and they understand that it's not a death sentence.
Sure.
And then once that's accomplished, because the woman with epilepsy needs a lot of support, so it's important to have everyone on board. Then we pick the right medication and we make sure we find something without side effects. And the two medications you should never use in epilepsy, the first one is Depakote.
Okay.
Because we all know from all the studies, there's actually pregnancy registries that have been going on for 20 years looking at these medications. They've shown that they have major malformations associated with Depakote. So if someone's on Depakote and they're within the first trimester, I bring them into the hospital, monitor them with the brainwave, take them off Depakote and put them on something else, usually Keppra.
Okay.
Because it's IV and we can get it in quickly. And
sure, the levels can be reached sooner.
Exactly. If we have the luxury of them saying, I want to plan a family, then we try to switch them over or start them on either Lamictal, which has only been shown to have very few cases of cleft palate in the last 15 years, or we try to use Keppra, or in some cases if they're, we try not to use Topamax as much, but some patients are only responsive to Topamax, so we try to do that. If you see a patient in the second trimester and they're already well into their pregnancy, that's where it's not recommended to change the medications, but we monitor them very frequently. In general, I see a patient every month until the third trimester, and then I see them every 2 weeks.
Okay.
And the last trimester and the last month, I actually check their vitamin K because we want to worry about the fetal anticoagulation syndrome. And we check their levels every month. And it's a big commitment from the patient and from me, but I find that when I do this, I mean, I've treated many women with epilepsy, they have a wonderful pregnancy, and they call me the day they're pregnant. On the phone, I make sure that I know I have on my calendar, and I check, because the day the baby's born, especially with Lamictal, your levels rise precipitously. So you have to lower the level by half.
Correct. And
other medications are the same way. So because the body surface area is much bigger, and then you deliver the baby and it drops. So that's when you really want to monitor them closely. The first. You should typically
and also hormonally, the levels changes so quickly.
Yes.
So I think that's the very vulnerable time, especially even with a lot of other disorders like cardiac issue and stuff, because so much changes are happening during labor and immediate postpartum that we need to monitor the levels and make sure that they are well controlled. So hopefully, it depends on the gynecologist to start having this dialogue even before they get pregnant. So if I have a patient with epilepsy, we talk about contraception in very, very, you don't want to get pregnant when your seizures are not controlled. If you do get pregnant, you want to control it before you plan pregnancy and change the medication. It's easier to change it when you're not pregnant.
Absolutely.
And monitor it and have seizure-free, and then we monitor with the help of neurologists and take it from there. What is the most worrisome for you? The congenital anomalies, the heart defects? What's usually the cause where patients will come and say, I'm really worried, be it cleft palate or...
I find that most patients are really worried about the intelligence of the child. They really want to know if this child will be normal, because I don't think they know enough about the malformations that can be possible, which is a good thing. But in terms of that, there's a wonderful neuropsychologist called Kimford Metter. He's done tons of studies, and I had the privilege of looking at it and writing a chapter about it. And he found that the older medications, Trileptal and Depakote, have a higher incidence of low IQ and dullness as compared to the newer ones. So he's continuing to do tons of studies on this, and new information's coming out. But that's another reason why the newer antiepileptics are better. And we counsel them. And you know, the other thing is breastfeeding.
Right.
A lot of people are very wary of breastfeeding. So we give them the data. I mean, once again, the older ones are higher in concentration, the newer ones are not. And we tell them the data and we let them make the choice, because some women really would like to breastfeed.
Right.
And I think with the newer medications, it's okay. I've seen women who breastfeed with Keppra. And I think the big problem is the lactation services in the hospital are not aware of this.
Right.
And it's also wonderful that you counsel patients about epilepsy, but I find that most OBGYNs do not link up with an epilepsy specialist, and they try to forge through it on their own, which is admirable. But I think that if we all work together, we can definitely, as a team, the patient will definitely do well. I mean, I've had patients who said, Dr. I wanted to breastfeed, but everyone discouraged me, and then, you know, I just couldn't do it. So that's sad, because it's not an end-all be-all that you can't breastfeed when you're on epilepsy medications.
Right. So I don't know, I counsel sometimes my patient that you really want to be epilepsy-free rather than have seizures. That's when you're going to cause more hypoxia and damage to your baby. So that worry about IQ and stuff, I think, you know, it's the way we counsel our patient that it's better to have it under control and take that very, very small chance of any, you know, neurological IQ effect, rather than have multiple seizures, have hypoxia, and have, you know, more damage to the baby. And most patients do, you know, correlate that and understand why it is, because, you know, when you have uncontrolled seizures, and especially we see because of eclampsia, you know, we see seizure disorders where they don't have underlying epilepsy. It's because of the blood pressure issues, and we've seen the baby's heart rate really, you know, change and have so many, you know, side effects on the ability of the baby to breathe and, you know, have a normal APGAR and IQ score. So I think that's very important that they understand why it's, you know, they should have, when they are younger and they're healthier and they're not pregnant, even if they have seizures, apart from the, you know, falling and having that kind of effect is dangerous, but you're not harming the baby. When you're pregnant, it's so important that, you know, not only is your health, but your baby's health is really important.
Yes, that's a really good point. And that's why if you have a patient who wants to get pregnant and is having intractable epilepsy,
right,
it's important to consult an epileptologist, get video EEG monitoring, because I find that most seizures can be controlled. With the amount of medications we also have something called vagal nerve stimulation, which is a small implantable device in the anterior chest wall that delivers electrical stimulus through the vagus nerve. And that helps as well. And that is not something which is contraindicated in pregnancy. And when the patient feels a seizure, they can swipe the mechanism and stop the seizure. So we have a lot of new modalities that are out there, and it's very rare. It is common. I mean, it's 30% of patients that are intractable, but I think with an epileptologist's help, you can find a treatment for every patient. And you're absolutely right in saying that one generalized seizure can cause so much hypoxia and so many complications. That's why it's really important to watch these women every month, because they do not report well, and they won't call you because they're scared. So sometimes you have to call them, or you have to see them more frequently and make sure you check their levels and find out why they're having this. I mean, sometimes they might just be having complex partial seizures, but you have to treat the complex partial seizures, even those you have to treat in pregnancy, because if you don't, they can progress.
Right, right. And let's go to some sensitive topic. Most cultures have some sort of stigma attached to seizure disorders. They either think that this person is possessed or has some abnormality, or they think they are crazy, or they are faking it, or they have some psychiatric illness. How do you counsel that? Do you have a psychotherapist work with you, or you kind of sit with them? Because I think it's so much information we need to give and educate patients. How do you go about that area?
Well, there is a type of epilepsy called non-epileptic seizures, which can be caused by childhood trauma. There have been a lot of studies on this. And those seizures, when you monitor people on the video EEG, you don't see epileptic changes. But clinically you see it. So, and these present in a very unusual manner. They present for long periods of time. Those, we need the help of a psychiatrist.
Okay.
And the second type, and secondly, there's a big comorbidity with anxiety and depression with all types of epilepsy, because you're having neurochemical changes going on with untreated epilepsy. And Dr. Davinsky has done some great work on that, as has Dr. Lankman, my boss. And we start people on antidepressants. We're very keen. We actually counsel them about that. We do neuropsychological testing on all of our patients, especially those who we think are candidates for epilepsy surgery. And that's another important point. Once you fail 2 medications, that person should be referred to an epilepsy center such as ours, which does epilepsy surgery in Hackensack. And we should try to see if they're candidates for surgery. It's a really big science now, the way we evaluate people. So we do sort of like a mini psych evaluation and counseling while we see every patient and give them the diagnosis. And if need be, if we think they're depressed, we refer them to a psychiatrist.
Wow.
Ideally, it's in our group, but we usually have somebody that we can send them to.
Right. So I think we talked a lot about epilepsy and seizure disorders. What are the causes, how we diagnose, how we treat, and especially with women, because I think they're going to get pregnant or they're going to get married. There's so much questions, and I think, this 26, 28 minutes is not going to give us all the information, but I hope this talk took out some of the stigma attached to it. These people, if they're treated well by a specialist, they can have a really normal, healthy lifestyle, pregnancy, lactation, and childbirth. And the whole idea is that this is not something that we have to shy away, we have to hide, because if there's early diagnosis and treatment, we can help this patient. So please watch the show again on YouTube. If your friends or family, anybody that you think will be really in need of such, Dr. Rao's information is on the site, and hope to see you next time. Good night.
When your family's in need of medical care, where should you turn? Come to Englewood Hospital, home of the most advanced technologies and medical equipment. Home to Magnet Award-winning nurses who deliver compassionate professional care. And home to more top-rated doctors than any other hospital in North Jersey. For your family's health, come to Englewood Hospital. We're closer than you think.